In the following program, three leading experts in nutrition and gastroenterology, Drs. Carvalho, McClave, and Deleghi, engage in a spirited and informative discussion on the nutritional management of complex patients. Each physician shares a case study in which enteral nutrition was successfully used despite numerous obstacles.
And I'm still fascinated by, I'd say, the hundreds of ways that we define gut dysfunction and or intolerance, or things such as gastric residuals, which you've written a lot about, where we're turning on and turning off the tube feeding, and from the perspective of everything we've been talking about, preserving the gut, like the villi, all those things get in the way.
Right. There's a whole area where the perception of intolerance is just inaccurate. One is inappropriately low gastric residual volumes. Another is the listening audibly to bowel sounds as a marker of contractility. That's fraught with all kinds of problems. So sometimes the perception of gut compromise is in error.
I mean, from the pediatric side, do you deal with gastric residuals? At all?
Yeah, so the only time we do deal with gastric residuals are in the neonatal population, children who are either born premature or within the first 28 days of life. And in those children, we measure residuals primarily as an indicator of gut motility and function, particularly when we're looking for preventing conditions like necrotizing enterocolitis, which occurs in a lot of these babies. And there are various hypotheses which include either ischemic compromise to the gut, bacterial flora in the gut, as well as medications, and secondary problems outside of the gut which can compromise the gut related to lung and heart function. So that's the only time we actually measure and look at residual volumes in pediatrics. We don't do it in the older children and the elderly population.
I still struggle with things such as nausea. I mean, here's one thing I always is a burr under my saddle, so to speak, is the fact that somebody will vomit in the hospital, one of our patients, and it turns into a medical emergency. Suddenly, all the tube feeding shut off. There are 14 drugs that are ordered. The patient's made NPO for 2 or 3 days. Then they're started back on clear liquids. Meanwhile, we're 3 or 4 days behind. Even when I'm sick at home myself, I don't sit around and say, okay, I vomited yesterday. Today I'm only doing clears, and if I'm good, tomorrow I'll let myself have some full liquids and kind of walk myself up that whole paradigm there. So I guess what I'm getting at is the fact that intolerance is defined differently to different people. We do need some good definitions, and then we need to know what to do about that.
Another perfect example of that is bowel wall edema. You'll have bowels in a bag where you can actually see the intestines, and the surgeon will see that and say there's bowel wall edema, we can't feed by the gut. As a gastroenterologist, that would not stop me. We've got great formulas in that situation we can utilize. The fact that the albumin level is below a certain number, 2.5, that we're gonna have bowel wall edema and compromised gut, that's not a contraindication.
I mean, do you feel like just changing the content of an enteral formulation can help us with that?
Oh yeah. When I have a compromised gut and I need to optimize absorption, then I'm going to want to switch from intact protein to small peptides, and I'm going to want to switch from long chain fat to medium chain triglycerides.
You do have some options. So somebody comes into the hospital and I'm wondering what I want to give to them for nutritional therapy, you're at a branch point immediately. Generally, or if they are eating, they're not doing very well from their eating. I guess kind of like your inflammatory bowel disease patients who, when they eat may actually be somewhat worse. And then we're always faced, the three of us, with making decisions about, do we use parenteral or enteral nutrition? And that parenteral nutrition obviously is another nutritional therapy. My experience so far has been this, especially in the ICU. I always joke with the nurses and say, everybody who is in the ICU has a central line, including people visiting. Get one when they come visit, because it's easy to put in where they use it for other things. So, intuitively, it'd be easy to give parenteral nutrition since you have central access. But I think the data over the past 10 years has been pretty good about telling us that's not the appropriate thing to do. The question, and Steve, I have this for you to start off with, is what do you do with people who don't get that? Meaning, I've been beating my head against the wall, and I can tell you that still, when we go look at the number of inappropriate PNs, people who should be on enteral, they have a functional GI tract, still about 40%.
It's the number's high, and there are a couple easy rules. If you're starting TPN and you anticipate a short term, less than 7 days, that's inappropriate, because you just cannot see any benefit from less than 7 days of TPN therapy, and you just expose them to risk and cost. The other issues are more subtle. Because they've perceived that there's a compromised gut, or they've perceived that the patient is intolerant and that they have to go to TPN. And that's harder to deal with. That's education. You know, choosing TPN because you had a residual volume above 150, or choosing TPN because you can't hear bowel sounds, because the patient's had nausea, vomiting, and you don't have the skills to get the tube below the stomach. Those are not really appropriate indications for TPN, and that takes education. It's a lot harder job.
So from our perspective, the only time we actually use TPN for a shorter period of time is that in the younger child, because a younger child doesn't have those reserves and stores like a young adolescent would or an adult does. So if you're looking at children who are under the age of 6, sometimes if they come in for a surgery, which they've suffered a complication and gone on for a little bit longer, they tend to get catabolic if you don't introduce parenteral nutrition. But we also don't need, we're not looking at giving goal calories, we're just looking at giving them some amount of protein to kind of help with the process of wound healing till that point in time where the bowel has either, the surgery has either got into a point where we can now start feeding their gut. So we do use TPN for short periods of time, sometimes in children, but it's only to prevent them getting into a catabolic state, which once you get into that, then your medications are not going to work. You're going to change a lot of your homeostatic mechanisms in the body. But we are very aggressive, I think most pediatricians and pediatric gastroenterologists are, of getting kids off TPN as quickly as possible, even when you're born with conditions like short gut and conditions like that, because we understand the long-term implications these can have, even in the developing liver. In addition to that, all the line infections, which do come in whenever you have a central line and you complicate the issue as well. So I completely agree. We tend to be very aggressive in pediatrics. And
Ryan, what's different in adults, I think, are we really have 3 choices when we approach a patient: enteral, parenteral, or do nothing, standard therapy. And in the adult population, particularly if they were well nourished when they came into the hospital, if enteral feeding is clearly the first choice and has the best outcome. But if that is not feasible, then in that first week of hospitalization, sometimes the outcome is better doing nothing than doing TPN. And if docs realize that the alternative to enteral feeding is not TPN, but is to do nothing, it might put a little more pressure on, you know, getting the access in and getting the feeds going.
And, you know, that comes down to stratifying the patients. And what I mean by that is, I mean, obviously, if someone comes in, they're severely malnourished, and you're not able to start enteral, then
TPN.
In the adult side at least, we're going to jump to TPN because they're at significant risk. What's wrong is what I hear is where somebody's going to surgery who's well nourished, but they may be in a hospital for a few days and someone wants to beef them up for 2 or 3 days before surgery. And obviously the beefing up leads to more complications because of the fact that it just doesn't make any sense. So, you know, when we talk a lot to our surgeons or GI colleagues or any specialist, we tend to say to them, what's the reason you can't use enteral nutrition? What's stopping you? And they usually have 1,000 reasons. But frankly,
a few of which are good.
Absolutely. Frankly, when you can sit down and kind of list those out and say, well, this doesn't really make any sense. And this doesn't make any sense, and this is very subjective. And people can see the fact that they can change outcomes with enteral. Then I think we're heading in the right direction. Ryan, all this talk about enteral nutrition and how important it is makes me realize that what we haven't discussed is actually enteral access, because you can't really give anybody enteral nutrition or formula without access. And I see that as being kind of a part of the science that gets left out sometimes.